Good evening, and thank you for joining us at the Minimally Invasive Urology Institute. We're very pleased to have Dr. Guion Parikh speak with us about prostate health. Dr. Parikh, please take it away.
Well, thank you for joining us during these interesting times. This is how we are conveying information and getting the public to understand a little bit about prostate health. We will today talk a little bit about men's health in general, but prostate specific to essentially urinary symptoms that may occur, which is known as BPH, and also we will go over prostate cancer a little bit. We'll get the next slide. So just a little bit about me. I am the director of the Minimally Invasive Urology Institute, also known as the MIUI, professor of surgery and medicine at the medical school here at Brown University. So just to begin, this is a sort of a very busy slide with a lot of various organs in the urology system. The way I would think about urology in general is essentially it's like plumbing. The kidneys are located here, and you can. I'm trying to put my cursor here on the kidneys. I hope you can see that. And then let me just make sure that that function is working. Well, in any case, at the top, these structures which look like little beans, these red, purplish things are called the kidneys, and then they lead to the pipe known as the ureter, which is essentially plumbing. The urine is made in the kidney, comes down the pipe, and comes to the bladder. And if you look at the bottom right here, you see the word prostate. The prostate is the organ located just below the bladder, which sort of supports the bladder a little bit, and you'll see that better on the next picture. So this is sort of a side view of things, and you can see that the ureters, which are at the top, bring the urine down to the bladder, which is essentially just a storage device. It stores urine, and then the urine comes through the urethra and out the penis. The prostate is located, as you can see, just below the bladder. So it's in a tough location, and often we'll describe how to examine it in a little bit, but it can present multiple problems, as we'll discuss tonight. So what does the prostate do? The prostate is a organ which really doesn't serve a ton of function as we get older, except it does produce fluid which makes up semen. Semen is the fluid that comes out when you ejaculate, and it helps sort of liquefy semen, we call it, or make sperm actually a little bit thinner so the sperm can swim faster. It also, as I said earlier, provides support for the bladder, so that if you do lose a prostate, and as we'll discuss in a little bit, one of the things that may occur is you may get issues with your urination, and we'll discuss how those can occur and how you can fix them and avoid them. So first thing I wanted to discuss was an enlarged prostate. It's very confusing when you read about this or experience symptoms. Your primary care doctor may talk about it as BPH or just EP, enlarged prostate, but essentially they're the same thing. One critical thing to understand is that this is not cancer. So BPH is not cancer. It's just a prostate which gets bigger with age. So most men, as we get older, will have an enlarged prostate, which is going to lead to urinary issues like going to the bathroom a lot or getting up at night a lot. And we'll talk about that. You just should understand that it's what happens with age, and it's very difficult to avoid, and it's a normal sort of occurrence. And it's diagnosed based on symptoms, usually going to your primary care doctor first, or if you're seeing a urologist for something else, then it could be brought up there. And also, the rectal exam can help guide us on enlarged prostate, which you should have annually with either your primary care physician or your urologist. So as we discussed earlier, the BPH occurs and will happen with age. So the general rule of thumb is 50% of men at the age of 50 will experience BPH, 80% of men at the age of 80. So most people, as they get older, will have BPH. So again, as we discussed earlier, when the prostate, which sits right below the bladder, starts enlarging, it enlarges on the inside. And if you think about it, as if like a pipe is getting blocked with, even a pipe at home. If you put something in the middle of it, it's going to get blocked. So the prostate, the middle portion of the prostate can sort of block the urinary flow, and that leads to symptoms like urgency, which is the feeling to go to the bathroom, but then when you get there, not much comes out. You can have a stream, classic description is, doc, I don't pee like when I was 18. So that's a weak stream. You feel like you're not empty. So you go to the bathroom, you get back to where you were, and then you feel like, don't feel satisfied. And then you have a difficulty to delay. It's tough to get the stream going. And then sometimes people also describe things like when a urine starts and stops. So what do you do? So the first thing, which should be with any real sort of non-cancerous type situation, is to modify your life. That means usually making a diet that's much better, which means avoiding dietary irritants. Sometimes these can be like caffeine. It could be spicy foods. These are various things that can cause urinary symptoms. So when patients come to me, the first thing I tell them is to modify their life, which essentially is eating a very healthy, balanced diet, as well as exercising. If that sort of doesn't work after, let's say, 4 to 6 months, I will then turn to medicines. There are multiple medicines available on the market, which we use. Some are what we call allopathic medicines, or medicines that are prescription-based, and others are more natural substances. Generally, the natural substances are unproven, based on trials, but some people do claim that they work well, and we will recommend certain things. But mainly we prescribe other medicines which can then manage the symptoms. If those medicines don't work, we can offer surgery or surgical intervention. And it's very confusing if you Google what the surgeries are for BPH, but they include TURP, which is an acronym for transurethral resection of the prostate, which means going in and cleaning up that prostate that's blocking the urethra. Often my patients will refer to it, it's kind of crude, but they refer to it as a rotor-rooter. Another procedure is something called urolift, which is a little less invasive, avoids some of the side effects associated normally with traditional procedures. And that's basically a mechanical procedure which opens up the prostate like a curtain so the urine doesn't have any blockage. Another procedure is laser surgery, or green light laser prostatectomy. And that's where you can go in through the penis without any cuts, all through a normal opening of the penis, and laser the prostate and decrease the amount of prostate that's blocking. And that opens up the channel so the urine can come out better. If someone's prostate is really big, and really big is defined by size, which we can measure, then we do what's called simple prostatectomy, which is sort of misleading because it's not that simple, but it is minimally invasive. And we use a robotic system which can go in and open and essentially take that part that's blocking the prostate out. And we can do this through little cuts in the belly, which can get the patient urinating better. So let's switch gears. That was sort of BPH. Again, to emphasize, BPH is not cancer. It is enlargement of the prostate, and it occurs in 50% of 50-year-olds, 80% of 80-year-olds. The other big thing that happens in this small organ located in this really tough area below the bladder is prostate cancer. Prostate cancer affects 1 in 6 males and will develop, and is the number one cancer in men. It's the third highest incidence of cancer diagnosis in Rhode Island overall, and it's the second leading cause of cancer death in men. 16%, so another way to look at it is 16% of men will die of prostate cancer. So the real question is, are you at risk? So the big thing to know, again, like BPH, it's rare to have it before the age of 40. And so the amount of cases go up after 40. It affects races a little differently, although some of this data may be a little bit off because there are new studies coming out that African Americans, who generally get a higher risk type disease and die more, may do so because there's less access to care. Maybe they don't get screened as aggressively and things like that. But in general, race does impact it right now. The low risk are in the Asian and Native American subgroups. Family history, if you have this is the big one. If you have a family history of prostate cancer, directly a father, uncle, then you're at higher risk. And then there's some association with genetics, like the BRCA genes, which are very studied very well now. And there's an association of prostate cancer in those families. Other things which seems to be linked to all cancers are smoking, tobacco use, exposure, obesity. There are also links to Agent Orange. If someone was in a war where their Agent Orange exposure was had, then that may be an increased link. Again, bad diet, high fat, red meats, charred meats are all linked to prostate cancer. So the problem with cancer in general, and including prostate cancer, it usually doesn't cause symptoms. If it does cause symptoms, that means it may be spread. Fortunately, usually it's not spread when it's found. Sometimes if there are changes that are occurring in the prostate, you can see blood in the urine, you could feel blockage symptoms like we described for BPH, and bone pain. But again, I don't want to confuse BPH and prostate cancer. Usually there's not any symptoms. So possible links and preventions that have been discussed in the past, and nothing is what we call in medicine level 1, which means it's absolutely the cause, avoid it. But there are some suggestions that if lycopene, which is the red substance in tomatoes, cruciferous vegetables like broccoli, cauliflower, antioxidants like vitamin E, selenium, healthy weight, being very physically active and with having a low body mass index, and eating soy may protect against prostate cancer. So the big question is, should we be screened? The problem is with screening of the prostate, it's located, as I discussed a couple times, in a very tough area. Fortunately, though, there is a blood test called a PSA, which is prostate-specific antigen, and it can be measured in the blood. It has had controversies because a lot of things can elevate the PSA, which make it look like there may be prostate cancer, and in general, it may lead to more sort of interventions or doctors trying to figure out if you have prostate cancer when they don't need to. Fortunately, having a good discussion with your doctor, maintaining a good relationship, following the PSA trend, there's a number of things you can use PSA for in a good way, and that's what we do here, and I think it's still a good test to utilize to be screened. When do you start? If you have risk factors, as I mentioned before, African American, or you've had a father who's had cancer, you start earlier at 45. And if there's any risk factors, even in double relatives, you can start at 40. There's different guidelines out there, and they basically are between 40 and 45. If you don't have any risk factors and you are just a first-time screener, then the guidelines generally say you can start screening at 55. So again, it's a blood test, PSA. It's a protein that sort of thins out the ejaculation. Its normal values are from 1 to 4. But remember, as I said, it's not perfect. So as we get older, the normal values do change. We call that age-specific PSA, which means PSA for a 50-year-old is different for a 60-year-old, for a 70-year-old. So the normals go up a little bit. So it's a good discussion to have with your either your primary care doctor or your urologist to see where you fit in. And again, there's other things that can raise the PSA. So it's not a cancer-specific marker, which means if you had sex the night before, if you had a catheter inserted, if you had infection, if you're on certain medicines, the PSA can bounce up. So screening should be individualized. As we discussed, it's based on risk and life expectancy. So if someone is 90 years old, you probably are not going to screen for prostate cancer. If someone's 50 years old with a family history or a relative with cancer, then screening should be done. Again, as I sort of talked about, it's a shared decision-making process. So getting screened doesn't mean getting your prostate out. Getting screened means decision-making based on what we find. If we do find signs that there are some worrisome things going on, then we would make some decisions and look for prostate cancer, which can be done with a biopsy or with other items. So there are a lot of tests out there. It's very confusing. Some are what we call biomarkers, which can look at proteins that are in the blood or the urine. Some are other tests will, look after you get a PSA. If it's up, then you could do the other tests to see if that PSA is really up because of cancer or something else. And it does, other tests also improve the diagnosis if something is clinically significant. That means, if you have a diagnosis of an elevated PSA or prostate cancer, then you can really figure out if it really needs to be treated. The big thing that's occurred over the last several years is prostate MRI has become very popular. MRI technology, when I started my career 15, 16 years ago, was very poor for the prostate. As time has gone on, especially over the last 5 to 6 years, we were able to show MRIs are very good for the prostate and really looking at whether you need a biopsy or help planning for certain surgical situations. So treatments are patient specific. So everyone's not the same. So if you have someone who you're sitting by at the bar or at a ball game and they say, I had a prostate cancer and had a prostatectomy, and then that's what you think you should have, well, that's not always the case. It depends on your what we call health, your age, and function. Some people say they go get radiation. It's non-invasive, don't get a prostate removed. Well, that may be true, but it may be true for the 75, 80-year-old and not for the 55-year-old. Some people don't get treated at all, and that's a true statement. There's a lot of prostate cancer that we follow now. Because, when I was training again and when I started my career, we would take a lot of prostates out because we didn't have any science to show us that the cancer wasn't very aggressive. Now we've learned a lot, and there are certain types of prostate cancer that are not aggressive and that we can leave alone. So those cancers can be what we call watched. But unfortunately, everyone is not the same. And so the key is to have a good discussion with your urologist to go over various options based on you and not anybody else. So the thing I discussed earlier, just on this last slide, was watching the prostate cancer. But that's called surveillance or active surveillance. And that really is only for people who are very compliant or those people who we know are going to follow up and we're on top of it. So that means we've told you have cancer, but we told you could watch it because it's not a lot of cancer or it's a certain type of cancer. So in those patients, we have to perform regular PSA testing. They may need multiple biopsies or they may need multiple MRIs to go over their various options and make sure that the disease is not going forward. And then certain percentage, maybe up to a third, 40% of people will progress. So we have to stay on top of it. But the way to look at that in a positive way is that maybe 60% won't progress. So it's a very specific, tailored treatment for patients. And again, discussion with the urologist is critical. Again, and just to go over that again, it's best for men with low-risk disease, which means very little amount of biopsies positive. A PSA is just borderline and things like that. So what we specialize in here at the Miriam Hospital, the Minimally Invasive Institute, is robotic prostatectomy, which is a minimally invasive surgery. In historically, maybe 15 years ago, we used to make big cuts under the abdomen, under the belly button, down to the pubic bone, and through that cut, we would have to remove the prostate. It was a very bloody operation because the prostate has a lot of blood vessels around it, and it was painful because of the incision. So as time has progressed, we brought on robotics here, and most robotic prostate surgery in the country is being performed for prostate cancer. It's minimally invasive. It uses a robotic system which allows us to see better, move better. It's three-dimensional imaging. It's sort of like playing a video game, but the surgeon actually moves to the side of the room, does the surgery on a console, and it is quite incredible and has really revolutionized everything in surgery. The laparoscopic approach is also used, not so common, through small incisions. What all these sort of minimally invasive approaches have done, the bottom line is they have decreased the amount of time you have to spend in the hospital. They've made quicker recovery, and blood loss has not become an issue, and most of our patients go home within a day. Other treatments, as we discussed earlier, are radiation therapy, hormone therapy, and rarely chemotherapy, which is reserved usually for the last two are more for a disease that's advanced and spread beyond the prostate. So at this point, I would entertain any questions. Thank you.
Thank you so much, Dr. Parikh. We've had a number of questions already come in throughout the presentation. Question 1, Given the controversy, do you still think the PSA is a good test? Should I be using this for screening?
So that's a good question. So PSA has gone up and down like other screening tests in its popularity. What I said before is critical. A PSA is very individual. So a PSA of 4 for a 55-year-old is different than a PSA of 4 for a 65-year-old. So to answer your question, it is very important. It's still the best test we have, but used in a very specific manner with a discussion with your urologist.
Very good, thank you. Another question that's come in. A prostate biopsy sounds quite scary. Is this done in the operating room? Can you tell me a little bit more about it?
Sure. Prostate biopsy is a pretty straightforward procedure, and we usually do it in the office. There's no IV sedation or anything like that, like one would get with a colonoscopy. We essentially put the patient on the side, and instead of doing an exam of the prostate with a finger, we can put an ultrasound inside, which views the prostate for us. We numb up the prostate with some anesthesia, local, and then we are able to take the biopsies. Total time in our hands is probably 5 to 6 minutes. There are complications associated with any procedure, but they're very rare, less than 1%. And we do a little bit of a prep or an antibiotic. It's very commonly done in the office. We do several hundred a year.
Another question that's come in. I've heard a fusion MRI ultrasound guided biopsy is superior than a regular ultrasound guided biopsy. Is this true?
So that remains, so it's a great question. Fusion biopsies are a little tricky because, as I said earlier, MRIs are getting better and better at diagnosing significant cancer in the prostate. And so if an MRI does show a lesion, certainly it should undergo what's called a fusion biopsy, which essentially means the MRI you had sort of goes over the internet and goes onto a special machine, not a regular biopsy machine, and that allows us to target the lesion specifically that the radiologist is reading versus the biopsy I described a couple of minutes ago. Is it better? Not necessarily. We know that prostate cancer can occur in multiple areas, even if the MRI is negative or doesn't show it. So, I think still the traditional biopsy is the way to go. And we reserve MRI right now in most cases for people who are having PSAs go up, but their biopsies have been negative, or to plan for surgery at the time for removing someone's prostate on how to proceed.
Great, thank you, Dr. Parikh. Another question that has come in. Is erectile dysfunction related to an enlarged prostate?
So good question. It is not usually. It may be related to some medicines that people are on. Erectile dysfunction is a very vague, it's not vague. It can be caused by multiple things, from blood flow to the penis to psychological things, and so on. So to answer your question, no, it is not directly related.
Thank you. Is there any utility in some of the prostate medications that I see late at night on the television?
So those are probably the natural substances that are occurring. Those occur, like saw palmetto is very popular. And then there's some other natural products. I don't comment on those to my patients much because I don't know. I don't know the evidence, and there's not studied. They're natural. They don't have to go through FDA approval. They may be based on some logical, historic things like, some cultural biases or things like that. Saw palmetto has been studied a little bit, and it showed some results. So as long as you trust where you're getting the product, it's usually not that harmful. But again, for me personally, I don't recommend it.
Okay, another question. In terms of prostate cancer treatments, which is superior? Can the prostate cancer come back if the prostate's removed?
So of the treatments, the surgery versus radiation is what I'm assuming. Are they specifying? Question to the host.
So the prostatectomy removal over radiation.
So again, it's very age specific and tailored to the patient. If someone is 80 years old, smoking, and they have heart issues, you're not going to subject them to surgery, and radiation will probably be the way to go. If it's surgery, we are recommending, usually the rule of thumb is greater than 10 years of life expectancy, someone who's relatively healthy, and so on. So is one better over the other? Surgery proves over a life to be better than radiation, but again, it's dependent on the age. Both are very good options for prostate cancer. But again, it's age dependent and how many issues you have. Like, do you have other comorbidities like diabetes, heart issues, things like that?
And the follow-up question to that, Dr. Parikh, is can the cancer come back after a prostatectomy?
Yes, the cancer can come back after any treatment for prostate cancer. As most cancers, cancer is very tough to deal with. But the way we deal with it is we watch it and we make sure it doesn't come back. And as time goes on, we are more and more assured. So that's why we use what we call 5-year data. So if someone is good for 5 years, and we have the luxury in prostate cancer to screen, we can use that PSA, which is tough for screening as we discussed, but for follow-up, it's great because you should not have any significant PSA. You do have a little bit left from other places, but we know how to monitor that. So to answer the question directly, it can come back, but we know statistically in the men we are doing surgery on, it's probably very low chance of coming back, 4 to 5%.
Thank you. Another question that's come in. I was treated by surgery for my BPH. Do I still need to be screened for prostate cancer?
Yes, great question. BPH, remember, is just removing the internal part of the prostate. Prostate cancer, unfortunately, occurs on the outside of the prostate that the BPH surgery does not touch. So every man screening for prostate cancer should, even if they've had surgery, should get screened for prostate cancer.
Fantastic. Thank you so much, Dr. Parikh. We're heading towards the end of our session here. So thank you so much for joining us and answering all of our questions. If any questions weren't able to be answered, we'll certainly be able to get back to you via email. So thank you so much for joining and have a great day.
Thank you. Good evening.